Hello, YouTube. We're back. I restarted the stream. I restarted the stream on YouTube because you guys were having audio problems. It happens. All right. Shelly says, do you think they will find a cure for IC? Oh, Shelly, I love this question because you're missing a real fundamental concept here. IC is not a bladder disease in the great majority of patients. It's not. And our national guidelines say that. Our national guidelines put out in 2022 by the American Urology Association flat out say we don't find bladder disease in the great majority of patients. But what they do find in the great majority of patients, 85% of IC patients, is pelvic injuries and extremely tight muscles. And there's a terrible legacy to having very, very tight muscles. The muscle, these pelvic floor muscles come off the spinal cord and then they're interwoven through, the nerves come off the spinal cord and they're interwoven through the pelvic floor. So when the pelvic floor muscles get tight, what do? They start squeezing things. They start squeezing nerves. They start squeezing blood vessels. And that dramatically restricts blood supply to the bladder and proper nerve functioning. So if your bladder is supposed to get 24 units of blood a day and it's only getting 10, are you going to have a healthy bladder? Of course not. So today we do something called phenotyping to try to figure out what group you're in, because gone are the days when everybody was told they had an incurable bladder disease. Man, that was 10 years ago. Today, patients are supposed to be told that you have a pelvic pain syndrome for which there are many potential causes. So, group number 1, Hunner's lesions. We now know that Hunner's lesions can be caused by viruses, viral infections. Your question is appropriate. Can we cure a viral infection? No, but we can control it with an antiviral, and that's the Epstein-Barr. But once you have a virus, whether it's herpes, HPV, etc., a virus is in our bodies. I have herpes. I've had, I get canker sores in my mouth all the time. I had a cold sore last week. Okay. The second cause of Hunner's lesions is neuroinflammation, often caused by a nerve that's being compromised by a weak ligament, the uterosacral ligament. Is that curable? Absolutely. But the correct question is not curable, it's heal. We heal injuries. We don't cure injuries, we heal injuries. So in our second group, which is bladder wall driven, we're going to look at a chemical injury. That's a distinct patient group. So if your symptoms started while you were going through chemotherapy, that's a chemical injury of the bladder wall. Is that curable? No, you don't cure an injury, you heal an injury. That is healable. If we can stop the chemical from irritating your bladder should heal. A good example of that, aside from chemotherapy, is ketamine. Ketamine is a rapidly growing recreational drug that basically acts as an industrial solvent to the bladder. And it's very, very damaging. And the patients who do ketamine addicts will just pee blood. And I work with them. We're the only group that does ketamine cystitis support. So I work with ketamine cystitis patients fairly frequently. And the high is so wonderful to them, they don't care if they're bleeding. But what they don't know is that it's literally dissolving their bladder. Is that curable? No. Can we heal it? Yes, as long as the damage hasn't really progressed. The second thing we're going to look for in the bladder wall group is estrogen atrophy, genitourinary syndrome of menopause. Is that curable? No, that's aging. But that's not a disease. That's dryness. That's dryness now. Sherry says here, that's me. I've been struggling with chemocystitis for 1.5 years now. Sherry, are you still going through chemo now, or are you done? So with the estrogen atrophy patients, we've got to look at the quality and health of our skin. What can we do to improve skin health? That, of course, is going to be topical estrogen, which helps that skin plump up and start to produce mucus. Sherry is no longer having chemo. Has it gotten better at all, honey? Do you feel like your bladder's on the healing pathway now with that with the chemocystitis? Let's go to our biggest phenotype. Our biggest phenotype is pelvic floor driven. Pelvic floor driven patients have muscles that are extremely tight that have caused ischemia in the pelvis. We've got muscle squeezing nerves and blood vessels. Is this curable? Absolutely, it is curable with pelvic floor physical therapy. The only time it's really not going to be is if we have a patient who doesn't want to do physical therapy, we've got a patient who has a really severe bony structure abnormality. So somebody who's got a really bad hip, really bad SI joint. I mean, my pelvic floor muscles on my left side are always tight because my SI joint's all funky and irritated. Sometimes bones cause problems with muscles. So we've got to know what the bony problem is. Sometimes it's your feet. If you're not walking correctly, if you're wearing high heels, that's going to tweak your pelvic floor badly. Our fourth group is pudendal neuralgia. These are patients who have muscles that are squeezing nerves. Is that curable? That's absolutely the wrong word. There's no disease. That is a biomechanical issue. That means that in moving your body in a certain position, that's pushing a muscle against a nerve, most likely. So we have to figure that out. We have to figure out, okay, what nerve is it? Where is it being compromised? How can we release it? And what can we do to calm those nerves down? That's going to be physical therapy, and that's going to be nerve calming medication. And then last but not least is our group of patients who have multiple pain conditions, the IC, the IBS, the vulvodynia, the TMJ. I'm in this group. Is this curable? It's not a disease. Is it healable? Yes. Widespread pain is a result of central nervous system trauma. It's a central nervous system injury. And it is the most complex and the most difficult of all of the phenotypes because when nerves get wound up, it is hard to wind them down. Patients get nervous system dysregulation. And the legacy of injuries often is very, very sensitive nerves. And so the injury might be long past, but the problem is that the nerve where you had the injury is still as sensitive as it can be. And so this is a different road because we have to be very invested in calming our central nervous system down. Patients who have multiple pain conditions are often stuck in fight or flight. They have a lot of anxiety. I have had and continue to have pretty significant amounts of anxiety. When your brain is in a state of anxiety, in a state of fight or flight, that acts to amplify pain throughout the entire body. Pain accompanied by anxiety is intensified by the brain. Pain accompanied by laughter is minimized by the brain. And so this is a bit of a reckoning, for lack of a better term. I have been much more attuned to this in the last 2 years than I have been in my entire life because for the first time I have been in crippling levels of stress, like stress that would literally have me in the fetal position. And that was because I was caring for my parents as they died, and then they died, and then I got breast cancer. And so now it's so weird, you kind of get stuck in your head a little bit as I'm working here, working on whatever stuff I'm working on for IC or talking with IC patients. I'm really trying to monitor my stress level. I had a really rough week last week because I had a customer who was angry for something that I had no control over at all. And I kept getting really nasty emails of like, I can't help you with this. That's your bank. It had nothing to do with me. And I could feel I could feel over a period of a couple of days my blood pressure going up and up and up. So for those of us who have widespread pain, we have to be much more attentive to our state of mind and our level of stress, and we've got to work consistently to calm it down. So, like, once that situation was settled, took a couple of days, it's settled. Finally, I could feel myself calm. I don't like making anybody upset. I believe me, I go over the top to make people as happy as I possibly can. In my office, the customer and I get very, very frustrated if I've got error. But when it happens, and we just have to deal with it. I just can't control how a bank operates. Yeah, so it was misplaced anger. So hold on a sec. Lots of questions. So getting back to Sherry, she's done with her chemo. It started after chemo, and you're not better. So, Cherry, a couple of things come to mind. Number one, if it was an estrogen-dependent cancer, they probably have you controlling and limiting your estrogen. Probably off of all estrogen. You might even be on Lupron to block estrogen. And that messes with the bladder badly because the bladder needs estrogen to produce mucus. So concept number one is, are you dealing with really severe estrogen atrophy? It's possible. Concept number two here is, do we have a nerve injury from that from the chemotherapy? It's not common. I'm going to say the great majority of patients that I've worked with who have had chemocystitis, that once the chemo is over, everything calms down. It's far more likely that might be something else going on. But I would really love to talk to you. If you ever want to talk, you can call me at the IC Network office. There's our phone number back there. It's 800-928-7496. Because it'd be really interesting to try to reveal what could be your underlying trigger. And so I'd be happy to try to phenotype you. Anne says, do you need an applicator with estrogen, or can you use your fingers? Sure, you can use your fingers, but an applicator will get it a little bit deeper. It's really about where is the skin the most uncomfortable. For me, my skin is the most uncomfortable on the outside, not on the inside. And so I rarely use an applicator. I just usually use my fingers on the outside with putting the estrogen on. Jerry says, I've had lots of physical therapy and 6 hydros, you still have chronic pain. So, Cherry, what did they see when they looked in your bladder when you had the hydros? Was it a normal bladder, or did you have Hunner's lesions? What did they see? Was it very red, inflamed? Shelly says she knows what she can eat and drink. Good. Okay. Cherry says she's on gabapentin and Tylenol. Okay, that's going to act to calm nerves down, but it might be interesting to throw in some PEA also, because the research behind this at calming nerves down is stellar. Judy says, does dry needling affect the pelvic floor? Yes, dry needling is used generally when they find a tight trigger point. If they find a muscle knot in your pelvis that they cannot massage out for one reason or another, they may use dry needling to try to get that trigger point and that muscle group to relax and release. Sherry says she has pain every day. Okay. Shelly says, all these years you have a disease. Well, okay. So again, that's the big thing. I mean, we've only been phenotyping for like the last 5 years. And we've talked about this extensively in a lot of our meetings and in our magazine and on our website. It was Dr. Christopher Payne years ago who proposed the first phenotypes. Well, his phenotyping system that I use, but actually it was Dr. Dan Shotsky and Curtis Nickel who created the very, very first phenotyping system called Viewpoint. Marlia says, do you think radiation from CAT scans can cause bladder damage? I've had 4 since 2021, 2 with contrast and 2 without. All scans were on except 2 small stones, which I have passed. I often feel my bladder is more sensitive since having them. I burn and feel dry. You're now using estradiol cream, but I just think the scans made things worse. It's doubtful because having a CT scan is very, very different than having radiation therapy. CT scans use the minimalist amount or the minimum amount of radiation to get a good picture. Whereas radiation therapy is using a lot of radiation to kill a freaking tumor. So is it possible that it might have irritated you a little bit? Sure. But I would assume that any of that minor damage it might have done would have long healed for you, Marlia. I really would. The question here, what I think is very interesting about what you just wrote is that you burn and you feel dry. Okay. And they gave you estradiol cream. A lot of women just completely underestimate how painful dryness is, how painful estrogen atrophy is. It is very, very painful. Sherry says she had like a leukemia. You had a blood cancer, honey. I'm so sorry. It's a okay. I mean, so like once somebody tells you you have a big cancer, it's very, very life changing. And I look in the mirror now, and I sometimes I see bags under my eyes and weariness just from the battle. She said, no Hunter's lesions, but very red. The first time it bled profusely. You're on bladder builder now too. So Cherry, I think one thing that you could do, just out of curiosity, and I suggested this to another patient who was recovering from chemocystitis, is lactoferrin. I mean, but lactoferrin in the IC study that was released last summer, red inflamed bladders became pink and healthy, and Hunter's lesions virtually disappeared. They almost completely disappeared. Lactoferrin is a frontline defense for our immune system. And so that would be potentially something worth adding to this mix to try what has been proven in good, solid research to reduce red inflammation. Again, those red inflamed bladders became pink and healthy after 4 to 5 months of lactoferrin. If you go over to the IC Network website, right on the front page, there's a blog on it that will give you all the research that you can read about that. Shelly says, where do you get Stellar at? Stellar? Where do you get the supplements at? We have them all in the IC Network shop. You can get them on our website if you want. Betsa said, what are the traces of blood in a urine test? This is also another really, really good question. And our AUA guidelines for IC actually increased their discussion of this. Now, many, if not most patients have microscopic blood in our urine. Every single time I've had my urine tested, it has had microscopic blood. And yet, every single time they've looked at my bladder, I have a perfect bladder. There is nothing physically wrong with my bladder. But I am a pelvic floor patient. But when my muscles get tight, it affects my bladder wall. You enter a state of ischemia. Your bladder's not getting enough blood supply to be healthy. It's not getting enough nutrition. It's not getting enough oxygen. The bladder wall becomes weaker with tight pelvic floor muscles. Thus, urine now penetrates into the bladder, penetrates more, and has a chance to penetrate more deeply into the bladder wall than normal. Well, your bladder wall is not passive. Your bladder wall is active. John, exactly. John says, I'm always positive for leukocytes. I'm going to explain this right now. Okay, mine is too. If you have a bladder wall flare from eating the wrong thing, or urine gets into your bladder wall signals your immune system that there's a problem. So your bladder wall is not passive. Your skin is not passive. There are nerves and communication signals happening all the time as these tissues communicate with the rest of your body if it has a problem. And so if we've got urine in the wrong spot, irritating those cells are going to release chemical mediators where they're going to get a message to your immune system and say, help, 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 something's hurting me. Your immune system then goes, okay, I'm going to send my warriors to the area. Your warriors are your leukocytes. So we've got urine in the bladder wall. It's not infection. It's just superficial irritation from urine. Your body doesn't know that. Your body sends your warriors, your leukocytes, to the area. They swarm the area in your blood vessel, your capillaries. But the fascinating question is how do they get out of the blood vessel into the tissue? And the answer is the blood vessel opens and releases them. The tiny capillaries in your bladder wall just open and they just let it all fly. And that drops leukocytes into the tissue, and that drops red blood cells in the tissue. That's why you have positive leukocytes for a blood flare, but negative nitrites when you do a dipstick test. And that's why most of us have a little bit of microscopic blood in your urine. Now, that's very different. If you are peeing bright red blood, or your toilet bowl is pink after you pee, that's a very, very different story. That is visible blood. And that requires a strong reaction on your part, because we have to figure that out. Why is your bladder or your kidney bleeding? A lot of times that's an infection, or that's a Hunter's ulcer that's bleeding. So microscopic blood, not a big deal. Usually not a big deal. Visible blood, potential big deal. And the big thing here is, are you a smoker? Because smoking is the #1 cause of bladder cancer. One of the earliest symptoms of bladder cancer is blood in your urine. So, and take it from a cancer patient, man, you do not wait. The earlier you catch it, the easier it is to treat. Do not sit on this for 6 months. If you're peeing blood, you need to get your tush to your doctor, and they need to figure this out. Because of all the cancers, bladder cancer is considered the easiest to treat. If you catch it early, it's really easily treatable and curable. But if you wait a year and you allow that cancer to grow into your bladder wall and then even maybe out of your bladder, it can be life-threatening. So we want to follow up on visible blood in your urine. Tanya says, can estrase cream cause irritation? I don't burn when I first use it, but burns the next day like crazy. That's really interesting, honey. I've never had anybody describe it that way. Maybe one person. The challenge with a brand name like estrase or Premarin is that they usually also have preservatives in them to extend shelf life. And so it may be that you're reacting to a preservative, or you could be reacting to something in the base. So this is why a lot of us get compounded estradiol cream, not a brand name. We get it made without preservatives. It's preservative free. That's what I do. I get mine from the Women's International Pharmacy. They have a new name now, but if you go to Women's International, you can see the new name. Artie says, "Hey Artie, I have severe Hunter's lesions. I've been taking lactoferrin for 3 months and my bladder is not any better. I've been taking my fifth cystoscope with fulguration next month. I bleed every day. I have extreme pain every time you pee. You also take PEA." Okay, so Artie, um, we had a really interesting case, just to give you an example, of a mother who had a 13-year-old daughter who had 7 Hunter's lesions. 7. Crazy. We never see that level of Hunter's lesions in children unless they have been exposed to mononucleosis, also known as Epstein-Barr. And so I asked her that. I said, "Have you had any mono in your home?" And she said, "As a matter of fact, we have." That her sister had severe mononucleosis about 9 months earlier. And we have multiple research studies now that have connected the Epstein-Barr virus, which causes mono, to Hunter's lesions. So concept number 1 here is, I think it would be very interesting for you to have a scan to see if you have any active viral infections. Because if you do, and they're already studying this, using a stronger antiviral medicine to get that virus under control might be reasonable. The second thing that we look for in Hunter's lesions is something that is causing nerves to become very, very inflamed. And so, again, when we're thinking about the pelvis and we're thinking about the nerves that travel throughout the pelvis, nerves are supposed to be in stable positions. And the interesting thing about nerves is they're often slippery and they slide. They slide back and forth. As you move your body, they will slide. This is good. We don't want things held in place. We want them to move and adapt as we move our body and adapt. But sometimes nerves get stuck in scar tissue. Sometimes nerves get stuck in tight muscles. And what happens then is that nerve gets very, very, very inflamed. And inflamed nerves release something called substance P, which causes wounds. So I would want to know, what the health of your pelvic floor is. Is your pelvic floor tight? Because if your pelvic floor is tight, that's going to compromise the nerves, which could lead to that neuroinflammatory process. And then the third thing that I think we look at, and there's something new too, is there any chance you have an autoimmune disorder? Any other autoimmune diseases? This is where something like cyclosporin might be something very interesting to explore. Cyclosporin is an immune suppressant. So it's often used by patients who have had kidney transplants, things like that. But in Hunter's lesion patients not responding to traditional therapies, cyclosporin has been life-changing to the point that some doctors have called it kind of their miracle drug. But it's a beast of a medication to take with a ton of side effects. So I would be going the viral route and the neuroinflammatory pelvic floor route first before I would consider cyclosporin. You're supposed to do that anyway. And sometimes lesions are just really, really resistant. And what they sometimes do is they will resect them out with surgery, just remove them entirely. I'm really concerned about you bleeding every day. To me, that implies potentially a viral infection, a pretty active viral infection. There's another virus called the polyoma virus. The polyoma virus is a virus that we all have. It's part of our normal biome. It gets turned on in patients who are immune compromised. and it is associated with what we call hemorrhagic cystitis. And in other words, bladders that bleed profusely. So I would be very tempted to go and explore potential viral origins for your symptom. You can call your primary care and just say, hey, I just learned that Hunter's lesions are sometimes connected to mononucleosis Epstein-Barr. Is there any way you can check me for that? The blood test? Let's see what that blood test reveals. And if it's showing active infection, that would explain why your lesions are not doing well and open up a new therapy for you, an antiviral. Sherry said, same for me. The estrogen cream burns an hour after using. I don't understand the mechanism for that. For me, when I've used my estrogen, it has always burnt, back in the old days when it did burn, it burned as soon as I put it on. Anne says, is there such a thing as an embedded UTI? Okay, embedded UTIs have been going around the internet for the last 30 years. Our challenge here is that the research simply hasn't found embedded UTI in the great majority of patients. We also used to call that a fastidious infection, a small infection deeper into the tissue. It was Dr. Paul Fugazzotto years ago who was the one who suggested that. And back then, back in the 1990s, we all sent him urine. I sent him urine. And he found Enterococcus and Micrococcus in the great majority of patients out there. What we ended up learning, though, is that the method that he was using, which was recycling little glass vials, do not kill some of these infections. So we think that his samples were contaminated. They were just contaminated. It is what it is. So now we have something called next generation DNA urine testing. Next generation DNA urine testing doesn't grow bacteria, it looks for DNA. It'll take your urine, it'll spin it up really fast, it'll break everything in there and leave fragments of DNA floating in your urine. They take that to identify the bacteria and the virus and the fungus. Next generation DNA urine testing will tell us the true health of your bladder. If that comes back negative, then you don't have embedded infection. If that comes back positive, say Enterococcus facilis or E. coli or something else. I was working with a patient like 2 weeks ago at it. An infection I'd never heard of, really nasty nosocomial infection. Started with an M. Crazy. Really, really rare infection. If that next generation testing finds something in a significant quantity, it will give you treatment recommendations. The other really cool thing about next generation DNA urine testing, it also identifies drug resistance genes. So it will rule out the bacteria that have no shot of helping you. All right, here, hold on a sec. I'm sorry on YouTube. I just kind of get we're going here. You guys, if I miss a question, please ask it again. Just be the squeaky wheel. Okay, I had a rectal prostate exam and it was painful and caused me burning after urinating. I had burning sensation urinating 2.5 years and was diagnosed with IC. I was not convinced that it was IC because I had the burning sensation when urinating at the doctor's exam. Didn't know that pelvic floor dysfunction causes pain and burning until I saw you. I don't speak English, but YouTube translates it into Arabic and I can read. Cool, excellent. I just started working. I may be working with a doctor in Qatar. I was sure then what happened to me was due to the prostate exam because 4 days after the exam, I had the burning sensation and it continued for 2 years. Sorry for the long post. I'm writing and translating into English because I want to know what happened. I also want to know how to treat pelvic floor. Thank you. Donna says, did I get your chat? No, I did not, Donna. All right. So getting back to the question, would a prostate exam cause pelvic floor dysfunction? I really don't think so. I think that the great majority of guys already have a pre-existing muscle problem, and the pelvic exam, the rectal exam, is going to push on these very sensitive, injured muscles. And that might have been, what we call the straw that broke the camel's back. That might have been that last thing which just turned all your pain on and turned on this burning. Generally what we see is a series of small injuries over time, like riding a bicycle, hitting your crotch on the bar of a bicycle, riding a motorcycle, falling on your tailbone, um, being involved in sports, getting hit in the pelvis, just little things here and here and here and here. And what you don't know is that those are taking a toll, that with every hit, your muscles are getting a little bit tighter and a little bit tighter and a little bit tighter. And eventually, those tight muscles can lead to the symptoms of frequency, urgency, pressure, pain. Um, um, the only scenario that I can think of is if a doctor was very aggressive. I had a doctor back in my 20s when my IBS was really bad. My primary care did a very aggressive rectal test that had me kicking my legs at him. And I think that was harmful. So how do we treat pelvic floor? With physical therapy. It requires physical therapy. And the challenge for you is going to be finding a physical therapist who does pelvic floor work in the Middle East. I'm not sure, what country are you in? Are you in Saudi Arabia? Let me look at my list here. I know that they just had a pelvic pain conference, I think, in Saudi Arabia in like the last 6 months. But here, hold on a sec. Let me look at a database here and let me see if I can. I know that we just had a big pelvic pain conference. Okay. If you go to pelvicrehab.com, there's one in the United Arab Emirates, there's one in Saudi Arabia, there's one in Egypt, there's a fully certified physical therapist in Jordan, there's one on Cyprus, fully certified one in Greece. Hey, this is so cool looking at this. And when we're fine, they're really starting to train physical therapists around the world now. I mean, the most are in North America, but it's looking good. Throughout Europe now, we got physical therapists that are trained. Yes. Yes, because we're long past the days of putting you on bladder meds that have no chance of helping. If you have tight pelvic floor muscles, we need to rehabilitate those muscles. So let me type this in here. So the database that you can use to find a physical therapist is at pelvicrehab.com. Artie says, I have a CAT scan Wednesday. I do estrogen daily, hoping for some answers soon. Good. I mean, again, I think that You've done fulguration after fulguration after fulguration. The lesions are recurring. We have to ask ourselves why. Why would your lesions be recurring? And that points right back to either a really active viral infection down in your urinary tract or something that is persistently irritating nerves. So I put my money, I mean, I wish the lactoferrin would, I wouldn't walk away from the lactoferrin because the IC study was about 5 months. You've only been on it 3 months. Give it a shot because that research is just so incredibly good and impressive. pelvicrehab.com. That's where we find stuff. So, so what's happening in my office right now? Almost done with the flare guide. I've added more flares. Now I have menstrual flares, I got urethral flares, I've got rectal flares, I've got prostate flares. I'm massively expanding the IC Network flare guide. And our flare guide are tips that you can use at home to try to nip this painful flare in the bud. And so we're giving, and I'm pulling from a lot of sources to find as many resources as I can for patients because I hate that you're suffering, and I know that because I have suffered. That's going to be our IC Optimus. That's going to take the place of our spring IC Optimus. Artie says he has 2 more bottles and we'll take them all. Thank you. You're welcome, honey. Keep in touch. I really, really want to try to help. I really want to try to figure this out for you. I mean, the lactoferrin study was just phenomenal. First study where red inflamed bladders became pink and healthy. And it's working for quite a few people, but for some people, some people can't take it for one reason or another. It gives them gas, gives them a stomach upset. That can happen. But I think you got nothing to lose. I mean, the safety profile of it was exceptional. And again, you can read all that on our website because I've got a link to lots of different articles on lactoferrin and many different research studies. So what the research shows that it's remarkably safe. So Donna, I did not get your chat. How did you send it to me? Let me look at my email here. Did you email it to me? Also, hey guys. Oh, and I haven't sent them out yet. I have to apologize. I have not sent out. I was really busy this week. Hold on. Where did they go? Okay. Would anybody like our restroom access card or our food card? I will send this to you no charge. All you need to do is email me your mailing address. You can buy 3 for $2.49 or $3.49 in our shop, but I will just give it to you. I just want to do that. And so anybody who wants our restroom access card or our diet card, pop me an email, icnetwork@mac.com, and I will happily send you cards. And I haven't sent the ones out from last week yet because I was really working on difficult situations this week. Okay. I am not wearing anything on my incisions right now, so they're talking to me. Marlia said, I had a UTI E. coli bacteria and had to take cephalexin for 7 days. It came back after 3 weeks. So the doctor said maybe I wasn't on the antibiotics long enough. So I had to take another 10 days. It did not work at all. I had the worst backaches and pelvic pain and pale pink blood. So the next urine sample showed Pseudomonas bacteria. So that meant 7 days on Cipro. That antibiotic scares me, but pick your poison, right? I think I showed signs of being antibiotic resistant, and that's a new scary dilemma. Marlia, I'm sorry, honey. That's awful. Um, and you're right. Cipro has a black box warning on it. It is now not meant to be used for simple UTI because it has so many risks of tendon ruptures and aortic aneurysms. It is now really only used for patients who have complex infections. So the question is your infection a complex infection? And for you, something like a next generation DNA urine test that will identify drug resistance genes makes total sense. It will the result will also give antibiotics that will treat that infection. So, you know, we're kind of stuck in a situation where health insurance companies don't want to pay for more aggressive testing. They're like, okay, you took the first antibiotic, didn't work, we'll put it on longer, it didn't work. Now we're going to throw out the Cipro with really big, which has pretty significant risk. There's a lot of guessing. There's a lot of guessing going on in that scenario, and I'm never comfortable with guessing. I like facts. And if I'm in pain, I really don't want a doctor to guess. I want really good data supporting that decision. And that's why I like the next generation DNA urine test, because it will tell us what we're dealing with completely, and anytime somebody has drug resistancies, especially multiple drug resistancies, we got to try to understand that a little bit more in depth, and next generation testing would do that. But anyway, I wish you well with your Cipro, honey. I really hope it works for you and nips the sucker right in the bud. Irene says, do you have any information on the eCoin? Supposedly it's similar to PTNS. Okay, I do. So post-tibial nerve stimulation is a technique that is used to try to restabilize nerves that are being funky. There are basically two different forms of neuromodulation. There is neuromodulation that's done up in the lower back, and there's neuromodulation that's done down by the ankle. Neuromodulation done in the lower back requires surgery. Neuromodulation done at the ankle does not normally require surgery. I did the ankle stim with the guy who invented the ankle stim procedure, Marshall Stoller at UCSF. And so, again, the operating assumption here for some, again, remember we're phenotyping now. Back when I did it 30 years ago, we all thought we had an incurable bladder disease. Now we know that's not necessarily the case, but there are some patients out there, a small group of patients who might have some funky nerve functioning going on, and that's where neuromodulation makes the most sense. The ankle stim is far less risky than the lower back surgery. There are hundreds and hundreds and hundreds, thousands of adverse events with the lower back surgery, sacral surgery. Not so with the ankle stim. A tiny number of adverse events, not significant adverse events. But the guys who invented that, of course, were looking for a way to perform neuromodulation that didn't require sticking a needle in your ankle. So they had been working on this concept of putting a little tiny round stimulator down by your ankle. And they were talking about this 30 years ago. It's taken a long time for them to do it. Now apparently it's available. I've never worked with a patient who's had it done. I've worked with thousands of patients who've had the ankle stim and the surgical stim, but not the eCoin. But now we're doing something that is a greater risk for adverse events, which is surgery again. So now that you're requiring that patient to have surgery, yes, it's a little tiny surgery right at the ankle, but that creates more risks. And that makes you more dependent on the doctor because they have to put it in and then they have to take it out. So that's 2 surgeries. So I never really understood this push, but I'm a patient. I'm a patient, and I'm a patient who's had it done. And the ankle stem is piece of cake. They taught me how to do it. It's like I don't need something a foreign body put in my a foreign object put in my ankle. I know how to do this. Just give me some acupuncture needles and a TENS unit. We can do it. So I guess to wrap it up, I haven't worked with anybody who's had it done. Would I do it? No. No, because I already know how easy it is to do the acupuncture needle, and there's just no risk with it. Tiny, tiny risk with it. And I'm really not interested in having a foreign object in my body. John said, I've had severe burning with urination since an aggressive rectal exam 6 years ago. Prostate secretions also showed E. coli and Enterococcus facilis, for which I took many rounds of antibiotics. John, thank you for sharing. Okay. So that helps us. That helps our gentleman over here on YouTube. You're not the only one. John had severe burning with urination since an aggressive rectal examination 6 years ago. It sounds like they really traumatized and injured a nerve. You know what? Hold on. I'm just curious. So the first things that pop up are that this can happen. Nerve injuries, particularly to the pelvic nerves, can occur during rectal exams in men, leading to various issues, including sexual dysfunction. These nerve injuries can affect both sympathetic and parasympathetic nerves. So, come on, give me the research. So are they calling it a pudendal nerve injury? Where does a pelvic? Okay, that's a 2011 study. A 2011 study. I want a bigger. I want a more recent study. Huh. John, and for the gentleman on YouTube, I'm sorry, I don't know your name. I'm going to reach out to some doctors. I'm going to see if I can find some research for you. I mean, rectal examinations are usually considered quite safe, but clearly I am getting hints from when I look at some of this research. Okay, I have to dive into this a little bit more. Okay, I can't do it right now, but I will. I promise you I will. Helena says, I've taken different types of pharmaceutical medications over the years for my long COVID, but nothing seems to work out as expected. You wasted a lot of money on drugs and things that didn't. Oh, honey, are you here to promote something? You are. Helena, this is a support group for men and women with pelvic issues. Yeah, we're not talking about long COVID. So, guys, do not use our chat to promote stuff, please. So disrespectful. Cherry said, I just bought this disc thing you put on your feet. You put your feet on that does the TENS and EMS. I tried it last night. It did seem to help a little, but it was just Cherry, can you put the brand name in? Let me look at it, honey. Okay, because there is something else. I was thinking of the surgical implant of the little dime size or nickel size implant, but you're right. I saw like in the last 10 days somebody promoting a round pad to put on the inside of your foot. Is that what you're referring to? I think that's what you're referring to. No data on that at all. Dawn says, have you ever had a patient who's taken Cytotec? It's not commonly used at all. Hold on. I'm trying to remember. I think we did an article on that. Like 3 years ago. Yeah, we did. We did. So it's based on old research, minimal research, that misoprostol can help reduce some inflammation. It is a prostaglandin analog. The 1998 study here's a 2018 study from Indonesia. Here's something in 2005 from our website, our forum. Let's see what she said. Here's somebody on it. This is in the IT Network forum. I have experienced a huge difference in the last 24 hours on misoprostol. Not saying this would help everyone. Probably would only help a minority of IT patients whose symptoms were worsened by using NSAIDs over the year, but maybe because I did tons of NSAIDs for literally decades. No wonder I kept getting worse on antihistamines instead of better. They were inhibiting my protective prostaglandin production even further. Okay. Doesn't come up very often. Tanya says, was just diagnosed with venous insufficiency of the feet and legs. Now I'm curious if this has anything to do with bladder symptoms or pelvic congestion. I'm atrophy driven, but wonder if I'm not having the best blood flow is the problem. I don't have leg pain or swelling, but you do have lots of broken capillaries. Well, isn't that interesting, Tanya? And they had a what's the name of the doctor who does blood supply? They brought a doctor into the International Pelvic Pain Society meeting like a year ago, opening up this whole new line of discussion about how do blood flow and circulatory issues affect the bladder. Here, hold on a sec. Hold on. So here it is. Facing Pelvic Pain is a book that's free on Kindle. And this is for people who have complex IC, and we just really cannot understand underlying causation. It's just like, we just don't get it. This is the book we go to because there are chapters that talk about, for example, what gynecological conditions can lead to pelvic pain, and then which male urologic conditions can lead to pelvic pain, what urogenital problems can lead to pelvic pain, what gastrointestinal problems can lead to pelvic pain, which musculoskeletal problems can lead to pelvic pain, what bone and ligament problems can lead to pelvic pain. I'm telling you, this is, for anybody who's really, really complex, this is the book that we go to. And so I know that they have a section in here, neurological problems. Let's go to rheumatal. Okay, here we go, vascular pain. Okay, hold on. Oh, sorry, my incisions are just killing me right now. Okay, how can blood vessels cause pelvic pain? What might suggest? Yes, okay, we found it, Tanya. So hold on. What is ischemic pelvic disease? Page 143. So let's go here. Okay, here we go. Here we go. Okay. Oops. How can blood vessels cause pelvic pain? Pelvic pain of venous vascular origin is referred to collectively as pelvic venous disorders. The veins are the vessels returning blood to the heart after it is circulated through the body, and the arteries deliver oxygenated blood. Pelvic venous disorders include pelvic congestion syndrome, which is basically a dilated vein, nutcracker syndrome, which is a blockage or stretching of left renal vein by anatomical compression of an artery against the aorta, and May-Thurner syndrome, which is an external compression of the pelvic iliac vein. Pelvic venous disorders are usually associated with vague or complex signs and symptoms from the swollen vessels. This can confuse practitioners, and the symptoms are often mistaken for other diseases like endometriosis, adhesions, fibroids, etc. They're usually seen in women of childbearing age, but they might occur in postmenopausal women who are on hormone replacement therapy. The pain can be caused by pelvic venous hypertension, increased venous pressure. So, girl, you need to get this book. I don't sell it, but it's free on Kindle. They talk about vasculitis, facing pelvic pain. I think Elise Day, DE, she's one of the young guns, one of the young IC researchers that represent our future. She taught at Harvard. I'm a co-author of this book too. I wrote the chapter on patient support. Facing pelvic pain. Outstanding resource, beautifully written, easy to read. It's written for patients who just don't understand and they're trying to solve the mystery of their pain. Cherry says, here's what I got. I got a foot massager for neuropathy. Oh, interesting. You know, Cherry, what's so weird for me, now remember, I'm a long-term pelvic floor patient, is that if I drive more than a half an hour, the bottom of my right foot gets hot. I mean, it gets like really, really hot, like it's burning. It feels like the accelerator paddle is red. Happened yesterday as I was driving home. I did a lot of driving yesterday. And then as soon as I get out of the car and I'm not sitting there, it goes away. If I cross my legs, it comes back. The bottom of my right foot gets really, really hot in that position where I'm sitting and driving. I've had this for years. Kim says, every time I take a statin drug, it flares me each time. I even tried Repatha, a non-statin drug, which flared me terribly. I have high cholesterol and some plaque in my arteries. I'm fearful of stroke or heart attack, but don't want this horrible bladder pain either. I feel stuck. Do I have any info on statins and IC? Yes, we have talked about that somewhat extensively over in the IC Network forum. And we just talked about it again like 2 months ago. Ah, what did we do? Don't think we did a blog on it. Okay, I'm trying to remember what we did. Because I'm running around like a chicken with my head cut off most of the time, guys. I am so freaking busy. It's ridiculous. I know I did something. Here, hold on. Let me log into my forum. So the IC Network, it's a first home for all IC discussions. We have a massive support forum, over 53,000 members. Great research. Forums are not used very often anymore. All right, so here's somebody who had a flare after taking a statin. Oh, this was just a week ago. Hold on. Oh, just finished an interesting group of studies on different statins and results. Here's what I learned in a nutshell. The oldest and most studied is lovastatin or Mevacor. Mevacor and Prevacol have the lowest rates of muscular problems. Lipitor and Zocor are in the middle. And here's somebody, horrible flare on Lipitor. Oh, here it is. Here it is. I knew. If you've regularly used statin medications to lower cholesterol levels and had your IC begin after you began their use, you should find this new study interesting. Researchers in Taiwan have determined that long-term and irregular use of statin medication is significantly linked to the development of interstitial cystitis. Previous studies found that statins induced cell apoptosis and inhibited the growth of epithelial cells in the prostate. Researchers presume that the same is occurring in statin patients who develop IC. Statins appear to induce inflammation via the production of inflammatory cytokines. By inducing neurogenic inflammation, statins lead to, quote, abnormal bladder permeability and changes in bladder sensation. All right, so hold on. Where did I get this? So that came from Renal and Urology News. And of course, it's not on their website anymore. Okay. You're not alone, girl. You're not alone. Lipitor appears to be the worst. I need to do an article on that too. I got to make a note. Hold on. I have my giant list of topics here. What was the other thing I said I would do? What else did I say I was going to do? Radiation cystitis. Oh, I know what it was. Okay, hold on. All right. Boy, you guys, you keep me working. I am always working. Okay, Donna said, had a hysteroscopy about 1 month ago. I had a feeling of pressure and pain in the vagina. What could be causing pressure and pain? Had the surgery due to postmenopausal bleeding. You also had a DNC. So I've had a hysteroscopy and DNC too. And then I had a hysterectomy and now it's all gone. Um, so are you saying that you had the pressure and pain? You have the pressure and pain in your vagina now after that was done, or was that before you had that done? What causing the pressure pain? I had surgery due to postmenopausal bleeding. Well, I mean, a couple of things come to mind. First thing that comes to mind is that that's a painful test that causes a lot of discomfort, and your body is going to react to that pain by tightening muscles. It's called the guarding reflex. So there's always a chance that your muscles are locked down into tension. There is there are complications from the procedure. Could you have um, a seroma in there or something like that? Kind of a large a large grouping of blood from bleeding that's just kind of stuck there. I think that that's a really important conversation to have with the doctor who did that for you. If this is new, I will tell you for me. Okay, after I had my hysterectomy, I had pulling sensation in my vagina. And every time I sat down, especially if I sat down hard, like, how you kind of drop down into your car seat. Oh my God. It was just like this pain, this sharp pulling pain in my vagina. And that turned out to be spasms of my levator ani muscle. When your muscles are tight, it can feel like there's something stuck up there. It can feel like there's a foreign object up there in your vagina, in your rectum, even in your urethra. Sometimes there's a pushing upward, sometimes there's a pulling downward. So when I finally got back to see my surgeon months later, and I was having this persistent pain whenever I sat down, he could see my muscles quivering. He's like, "You're having involuntary muscle spasms." I'm like, "Okay, what do we do about it?" He's like, "Physical therapy." I'm like, "Sign me up, baby. Sign me up," because it was miserable to live with. Is there a difference between bladder sensitivity and interstitial cystitis? No. Interstitial cystitis doesn't really mean anything, honey. It's a name we're all getting most of the world is no longer using. It implies that it incorrectly implies that there's a problem with the interstitial layer of the bladder wall, and that's not true, and that was disproven decades ago. Most of the world calls it pelvic pain syndrome or bladder pain syndrome, a syndrome for which there are many potential causes. And so, how is it diagnosed? You've got symptoms of frequency, urgency, pressure, pain, in the absence of infection. You have all the symptoms of infection, but they don't find infection. That's usually the first screening for a diagnosis. Is everyone who's irritated by eating diagnosed with interstitial cystitis? No. We know men with prostatitis have similar diet issues. Um, we know that women with estrogen atrophy, men going through chemocystitis, they're all going to have some diet sensitivity because their bladder wall's compromised. Is it true that IC is caused by bacteria and that is the cause of pain? And if antibiotics are taken for a longer period, the patient will recover? Absolutely not true. That's something that's happening on the internet that has been disproven over and over again by major researchers. Donna says she's going back this week. I feel crazy asking the doctor again. No, don't be persistent. You don't, this is not you being crazy. This is about you suffering. Rebecca said, and you guys, again, I apologize. If you see me squirming, it's just because I had breast cancer surgery. And my incisions are, and the scar tissue is really bad. So Rebecca said, I just finished Cipro. It's my third antibiotic. I think my utilization pain. Okay, cool. Done. Kim, you're welcome. Kim said, thank you, Jill. You're welcome for the star. Appreciate it. You guys, if you find these meetings helpful, please come on over to the IC Network and you can sign up to get our free newsletter. I write it. We don't send out spam. Where you get all the latest news on IC, exclusive content for our members. All right. Okay, so we've been going on for about 2 hours now. Good meeting so far. Really like your question. So I'm here as long as you have questions. So give me your question. Now I'm going to confess that I have eaten nothing today other than a half of a banana. And I'm starting to get hungry. So I'm going to go get the second half of my banana. I will be right back. All right. I hate to eat on camera, but I have to. Any other questions out there? Any other questions? I am happy to take any questions you have. If not, sometimes our meetings go 5 hours, sometimes they go 45 minutes. We're at 2 hours now. I'm happy to take any questions that you have. But if you think you're done, then we can be done. That's okay too. Christy says, what do you suggest to take? I'm having a posterior prolapse repair. Okay. So Christy, do we know what triggered the prolapse? So prolapses are usually triggered by difficult childbirth, where you've strained the muscles, or they're triggered by estrogen loss and muscles getting weaker. And so concept number one here is what is the overall health of your skin? What role is estrogen loss playing in the weakening of your muscles? And if the doctor has made that connection, are you doing any topical estrogen? We've got to, listen, getting old sucks. I was just talking to somebody about it this morning. It is so weird to be older because in my brain, I'm 25, but my body will be 65 in July. And going through the changes of aging is baffling. I know that I have muscle loss now that I didn't have a couple of years ago. That's from estrogen loss. Christy says, yes, estrogen loss. You're using estrogen cream. So, okay, so we're working on the skin. In the same context, estrogen is going to help your bladder a bit, hopefully more than a bit, but some patients simply don't have enough mucus in their bladder to protect their bladder. And so you might benefit if you're suffering from bladder issues, you might benefit from bladder builder or bladder rest or one of the chondroitin-based supplements that gives your bladder a little bit of extra protection to kind of compensate for that estrogen loss. So that's one thing that you could consider adding to address bladder symptoms. To address muscle issues, to potentially be doing that pelvic. But once you're at the point where you've got a profound movement and prolapse, physical therapy is not going to be effective. And that's where they go in and they do the surgery. And it's good to have the surgery when you're young, because when you're older, and if you've got a really severe prolapse, you might not be able to fix it. So repairs are important. Getting organs back into the proper position is important. How they do that surgery is also important. Will they be using your natural tissue to get everything up where it needs to be, or are they going to be using a mesh? That's something you need to talk with your doctor about. Ask them the methods they're using, the source of the tissue. Your natural tissue is always going to be better. But there comes a point in time where mesh might need to do that if it's a really severe prolapse. And then understand that going through that surgery is necessary, but challenging, because on one hand, you're going to be on some pain meds, but the pain meds are going to make you constipated. And constipation on top of fresh pelvic surgery is a beast. And so you're going to want to follow all of their recommendations for stool softeners, because the last thing you want to do is you get constipated after you've had the surgery. Okay, good. They're using natural tissue. Excellent. At the same time, they're going to do an installation. Huh? They're going to do an installation after they do a prolapse repair. Well, I mean, they're kind of weird, but okay. If it'll calm and numb and soothe your bladder wall after surgery, power to you. Sometimes they do nerve blocks afterwards to really make that would be something definitely worth talking to your doctor about, is nerve block. Will they do some nerve blocks after you have the surgery to minimize your post-op pain? That would be very important. I mean, it's kind of weird that they would do a bladder installation while they do a prolapse repair. Normally, when they do any type of pelvic surgery down there, especially like a hysterectomy, they will look in the bladder anyway, just to make sure they didn't accidentally cut the bladder or damage the bladder. I mean, so when I had my hysterectomy, they did a hydrodistension with cystoscopy just to make sure they didn't damage my bladder. Piece of cake. And so I can understand them wanting to look in your bladder after doing that procedure. So they're saying, okay, well, it's a good time. Let's just put some stuff in there, just kind of calm it down. I would want to know what that is going to be. What's a bladder installation going to be? We don't want them to do an old bladder stripper like chlorpactin or silver nitrate. Those are not treatments for IC. They make it worse. So normally they would do a heparin lidocaine installation, something that will numb the tissue and coat the tissue. So ask what installation they're proposing to do. That would be very interesting. Hi, Kathleen. I remember you. A few weeks ago, you helped me with travel ideas for your Disney trip, and one was a stick-on heating pads. That was a game changer. Girl, it worked. It worked, right? How was your trip? I love Disney. I was watching a Disney live stream last night. Guys, listen, if you just need to be happy, you're having a rough day and you're trying to get yourself ready for bed or it's after dinner, you can go to YouTube and there are these group of people who walk through Disneyland and Disney World with their cameras. And they go on all the rides with their cameras. And last night was the 70th anniversary Disney celebration. They've got this beautiful light parade. It was like at 11 o'clock last night. I watched it. You know, Disney is kind of like our happy, safe place. John says, what's the treatment for pelvic floor congestion? It is indeed an interventional radiologist will do it. And I think they use like a little spiral thing. I don't know the name of it off the top of my head. Here, hold on. It's in this book. It's very treatable. And it's easily treatable. It's fairly easily treatable. I don't remember the name of it. Hold on. All right, page 34 and 35. Let's see what they say on this page 34 and 35. Pelvic congestion syndrome is a term used to describe dilated veins in the pelvis that cause pooling of blood in the pelvic organs. This is similar to varicose veins found elsewhere in the body and also in the legs. Classically, the pain is aching, throbbing, pressing, cramping. It increases with periods and occurs with prolonged standing or with intercourse or orgasm. It occurs most often in women who have given birth. The diagnosis can be suspected when pelvic varicosities are seen on an ultrasound. An MRI is considered as a diagnostic test of choice when dilation of the left gonadal vein is seen, because this is a sign of more significant backup of blood in the pelvis. Surgery on the vessels is important. Oh, here we go. An interventional radiology specialist can also treat this condition by placing a coil in the dilated vein to stop blood from running back into the pelvis. I was right. I called it a spiral. It's a coil. My memory is pretty good. Christy just ordered the PEA and the bladder builder. Good. I think that they are reasonable things to try. Kathleen said, had a rough time at the first with flares, but as soon as that subsided with some stretching and the little heating pads and really watching my diet, the rest of the trip was great. Wish I could have been there longer, but already planning the next trip. But now we'll be hopefully doing Disneyland. Yeah, I've never been to Disney World, but Disneyland, I've been to Disneyland. Honestly, oh my God. When I think about, I went to college in Santa Barbara and I worked the summers. I worked as a tennis pro, the 2 summers that I was there. I would have loved to work at Disney. I think, and my cousin worked at Disney when she was a teenager. She was one of the princesses. I don't know if I could have ever been a princess. I would have been perfectly happy driving the monorail. I love the monorail. So anybody out there with kids who are younger, remind them that you can work at Disney and that it could be a fantastic summer job. Like, I want to go work at Disney right now. It would be so fun, but I'm too old to stand on my feet that long now. I was looking at all the kids who were in this light parade last night going, yeah, there ain't no 65-year-old in that group. I think the oldest person in that parade was probably 25. Disney is awesome. Favorite ride? What's your favorite ride at Disney, guys? What is your favorite ride at Disneyland or Disney World? I will tell you mine every single time. Pirates of the Caribbean. Prove me wrong. There is no better ride on the planet than Pirates of the Caribbean. And as soon as the boat moves away and it's gotten dark and you see the little fireflies on the side and you hear the sounds of the swamp, and then there's a little cabin with an old guy sitting on the outside smoking and the light is flickering. It's just like you're in a world. You're just in such a wonderful little world. So, number 1, Pirates of the Caribbean. Number 2 for me, Monorail. Number 3, Haunted Mansion. But I have not been on any of the Star Wars rides. All I know now is that if I get startled, I might leak a little bit. So there will be pads worn if I ever go on any other busy rides. You know, that's the price of getting older. Kathleen said Pirates in Disneyland is way better than Pirates in Disney World, but oh my God, me too. I love the People Mover. That was like my other absolutely favorite ride, but they don't have it at Disneyland anymore. They have the track. The track is still there, but the People Mover got shut down, I don't know, like 20 years ago. I never understood why. Space Mountain is a cool roller coaster for sure. I just don't know if my pelvic floor can handle that now. I am older. Oh God, what else would I do? Small World is very loud and very annoying. That's the worst ride ever. It's not Small World, in my opinion. Jungle Cruise is pretty cool. I really like the Jungle Cruise there. We have anyway, I love watching the Disney streams. They just make me happy. When our world is so weird right now, and I'm working so hard on trying to reduce my stress level for my blood pressure, for my heart, and for the cancer, for all of that. And so after dinner, I just watch things that are happy. And so I watch British stuff. I watch old literally every night I watch an episode of the old comedy Are You Being Served? Because it just makes me happy before I go to bed. And I will watch Disney stuff. Give me a Disney movie anytime and I'm a happy girl, because on the inside I'm a little girl. Heather said, okay. Yeah, okay. All right, guys. Well, we've been going on for 2 hours and 10 minutes. Flowers provided by my niece. She has a massive, massive flower business. She sells to hotels. Dry Creek Flowers for anybody up here. Oh, John loves Hyacinth Bouquet. Yeah, see? What's the name of that series? What's the name of that series? I can see it. I can see it. I can see her. I can see her husband. I can see all of them. I just don't remember the name of the series, but the Hyacinth Bouquet comedy series is great. Are You Being Served with Mrs. Slocum, constantly talking about her pussy and her cat. It's funny when you go and you watch some of these old shows and you really realize they got away with a lot. And so Are You Being Served is just a classic British comedy that is devilishly funny and wry, with really wry adult humor in it. It's amazing. They got away with a lot. What else am I watching? I'm sick of watching shorts on YouTube. I do not watch TikTok at all. I canceled my TV service. I don't even have cable TV anymore. Funny. Life is weird, all the things that were important 20 years ago, 30 years ago, everything's changed. Change is going to happen whether we like it or not. So, all right, guys. Well, listen, I think we've come to the natural end of this meeting. You can always reach me. Call the IC Network, 800-928-7496. Come on over to the IC Network website, icnetwork.org. Always happy to take questions. My email address is icnetwork@mac.com. If anybody wants a free restroom card or a food card, all you have to do is email me your address. I will not be recording it into a database. I do not save any of that. I'm just going to put them in an envelope and and label it, and your email is going to be deleted. All right? Donna said all right, we're good. My friends, I will wish you well. Go outside, enjoy the sunshine a little bit more. I'm going to go plant some seeds. All right? See you later. I'm going to say goodbye to YouTube first. Hi, YouTube. Be well.